Dear friends, good evening, one and all. On behalf of Preeti Urology and Kidney Hospital and Pure Facebook group, today topic is a common topic, that is PCNL. As you all know, even after 30 years, 40 years, like TURP, PCNL has its own place. Any surgeon, not only in India, all over the world, especially who deal with stone diseases more commonly, cannot go away without doing PCNL. RIRS has come in the way, but it has limitations, and PCNL, prone PCNL is the one which is done by majority of the urologists across the world, more than 90%. Many times we discuss upper calyx, middle calyx, anatomy, the anterior calyx, posterior calyx, which is a safe calyx. To discuss all this, one of the most senior persons in India is Dr.S K PAL sir. And I will introduce S K PAL sir, everybody knows, but for the younger generation who are coming, nearly 300 juniors, maybe some people may not know about sir. So based on that, posterior calyx versus anterior calyx in prone PCNL is a topic given to sir today. And sir is entire life dedicated to the PCNL surgery as far as the academics concerned. Vast experience with a lot of live workshops experience, international lectures and international live workshops also, even in China, Pakistan. Very few people in India have gone to China and Pakistan and have operated, even in Europe also. So briefly, senior consultant urologist presently at Indraprastha Apollo Hospitals, New Delhi, India, convener USA urolithiasis subsection. That is also very important. This is the first urolithiasis subsection. After the subsections are formed, unanimously sir is elected. That is the amount of the academic interest sir has in the renal stone disease. Vice President of International Alliance of Urolithiasis. That is also very big group, and coming months we are also having the conference there also. President Golden Bridge Urological Association. Developed special interest in urolithiasis in 1986 and devoted his career on stone disease. Honestly, he is the MCH from Manipal, I think it is not mentioned here, and then he subsequently worked there, came to Delhi and established as a stone surgeon in Delhi. Completed 10,000 PCNL operations in July 2018 itself, and has organized 9 large international live operative workshops on PCNL every year in New Delhi, alternate year, called PERCON. We have the PERCON this year also. This year in the September, October 2nd, 3rd, I think the 3rd to 4th, we have the PERCON. Participated as live operating faculty for demonstration of various types of PCNL surgeries, nearly 184 live operative workshops. Yesterday I was counting, I have not reached even 100. As I am thinking, I was doing more. See, imagine 184 live surgeries is too much. All over the globe, including at China, Turkey, Doha, France, Netherlands, Iraq, Pakistan, Philippines, and Nepal. Entire Asia is very, very well known. Has been invited to deliver talks on various aspects of PCNL in international meetings of Society, International Urology, European Association of Urology, World Congress of Endourology, Challenges of Endourology, experts in stone disease, and during annual meetings of Chinese Urological Association, East Asian Society of Endourology, Pakistan Association of Urologists. So with this introduction, I like to hand over the program to S K PAL sir. S K PAL sir, thank you very much for giving the time, and over to you sir, please. Thank you.
Thank you, Dr. Chandra, for an elaborate introduction. Is my slide visible?
Yes, sir.
So first of all, I would like to wish a very happy Doctor's Day to all the amazing doctors who are attending this webinar. Your gist to learn the more and more and remain busy with the academics is really great. All doctors, they try to help their patients to their maximum capacity, and they must be congratulated for their zeal. I put salutes to Dr. Chandra Mohan, who has initiated this group of Pure Urology, and this group has 9,600 members, I think more than that now, and he has conducted so many conferences, so many pure urology talks on different practical aspects of urology, which must have benefited thousands of people. We always see him like this, and the same way he is listening very keenly to all the talks and I think imbibing knowledge. So today we will be discussing about posterior calyx versus anterior calyx during prone PCNL. Which calyx to puncture? I bring you greetings from the hospital, Indraprasth Apollo Hospital in New Delhi, where I am working these days. This is the most common question whenever we are attending a operative workshop on PCNL. Which calyx you are going to puncture and which should be punctured, anterior or posterior? And whenever this question has been thrown open to the house, most of the urosurgeons have always suggested to identify and puncture posterior calyx, only posterior calyx for all PCNLs. And rightly so, because concept of orientation of calyces in anterior and posterior calyx was suggested by Brodel 122 years ago in 1901 by anatomical dissections. He pointed out that the calyces are arranged in a anterior and posterior disposition, and most of the he mentioned all posterior calyces are lateral and anterior calyces are medial. This is the way he postulated that all posterior calyces, when the patient is lying prone, imagine the patient is lying prone, this is his back and this is his front, and this is the posterior calyx. So it is extending far laterally, which is quite amenable for puncturing during PCNL in prone position. So he at that time never conceptualized that there will be some technique called PCNL, but he mentioned all posterior calyces are lateral and anterior calyces are medial. Because there was not much of influence, nobody was doing any intervention surgery on kidney at that time, nobody questioned it, and this opinion was accepted for next 71 years, a long time. When many urologists, they got trained, then their teachers and their sub-teachers, everybody taught that posterior calyces are lateral. So this concept got fixed in our mind. When IVU was being used very easily, very commonly, then Hodgson pointed out by seeing the IVU that the concept of Brodel is not correct. He mentioned all anterior calyces are lateral, which are extending towards the periphery, and posterior calyces are medial. This was an absolutely reverse concept. Then CT scan also started being used in stone disease, and interventional urologist for the kidney started. In 1980, the things were going on, the concepts were developing, and then there was a concept in 1980. Anyway, at 1980s, everybody took granted that all posterior calyces are lateral. So, detailed calyceal anatomy for endourology. This article was published in 1984 when interventional endourologist and radiologist had started experimenting with the kidney, and there they studied 50 kidneys, 26 right kidneys and 24 left kidneys, which were subjected to IVU as well as CT scans, where you can identify the anterior versus posterior calyces. And this was the concept they thrown open, that yes, there are few kidneys which are Brodel's type, few kidneys which are Hodgson type, and then if you see on the right side, 70% of the kidneys are Brodel type, and on left side, 80% of the kidneys are of Hodgson type. But if you see broadly all the kidneys, 74% of the times, anterior calyces are situated more lateral. So they gave a concept in favor of Hodgson that anterior calyces are extended better. Now the controversy continued from 87 to 2001, 14 years. This gentleman, who was professor of anatomy, he used to take out the kidneys of cadavers. And during this time, PCNL was developing. Mind it, 1987 to 2001. He published 17 papers only on renal anatomy, anterior, posterior calyces, and their this relationship with the vasculature of the kidney, all those. And he was, although anatomy of he was a professor of anatomy in Brazil, he was granted a professorship of urology also because of his so much of contribution. And still we follow a lot of his teachings. What he mentioned, now you see very seriously what he mentioned, that there are two types of calyces, two types of pelvic calyceal system. Depending upon the drainage pattern from superior, middle, and inferior poles, there is group A, where there is no independent drainage from the mid zone. Only superior pole and inferior pole, there are independent drainages. And in group B, he put those pelvic calyceal systems which have all the three different independent drainages. So this was his group A. If you see, there are only two major calyces, one is superior, one is inferior, and the middle zone has no separate drainage. The upper half of the middle zone is draining through the superior calyx, and the lower half of the middle zone is draining through the inferior calyx. Very straightforward pelvic calyceal structure, and this was mentioned as type 1. Same way, when there are two calyces, but there is a reverse drainage, the upper half is draining to the lower calyx and the lower half is draining to the upper calyx, there is a crossed calyx, then this is called type 2. There were only 17% of such pelvic calyceal systems. In group B, there are all the three drainage systems are there from superior, middle, and inferior. If all the three are independent, this happens in about 20% of cases, and in about 16% of cases, the middle zone directly drains. There is no major infundibulum or middle calyx. These small calyces, they directly drain into the pelvis. So this is the way calyceal anatomy was developing and being understood. Further, he mentioned, now this comes to the practical aspect of it. Further, he mentioned that superior poles, this is for the knowledge of all those who are doing supine PCNLs, superior poles almost always have compound calyces which drain through the same single pelvis infundibulum into the pelvis. And they are only divided into lateral and medial part. This was mentioned in about 98% of superior poles. You can see all these pictures I have brought out. All are draining through the single infundibulum. All superior poles are draining through the single infundibulum. And Miller in 2013, he mentioned that its superior pole calyces are typically oriented in lateral and medial disposition. So in the superior pole, there is no question of anterior or posterior calyx. They are lateral and medial calyx. Coming to the middle calyx, middle calyceal group. In 95% of cases, calyces are arranged truly into the anterior and posterior disposition. So this is the only place, middle pole, where there is a true anterior and posterior calyx draining into the pelvis. Coming to the lower pole, if you study the anatomy of lower pole, Isner has done a very good study, and then they have mentioned, this article was lower pole fluoroscopy guided percutaneous renal access, which calyx is posterior, because everybody was talking that posterior calyx has to be punctured. So they studied the pelvic calyceal anatomy, and they said that they studied 101 units, and then they found out that lower poles are drained either through 2 or through 3 calyces. In this, I have taken out the picture where there are two calyxes. When there are two calyxes, this one is medial, this one is lateral. And it is the lateral calyx which is oriented posterior. I think it is clear in all these. This is the lateral calyx, this is the medial calyx. The lower calyx has got only two draining units, and this particular one, which is the lateral, is going to be the posteriorly oriented in 93% of cases. While those units where you see three calyces in the lower pole, it is only the middle one which is posterior. The medial and lateral one, they are all again anterior. But this happens only in 70% cases. Middle one is oriented posterior. And 31% cases, no calyx is truly posterior. All the calyces in the lower pole or draining are angled towards anterior. So this was enough of confusion created, and I must mention about Dr. T.R.S. Anjana from Thanjavur. She has studied 100 human kidneys, cadaveric kidneys, during her thesis for anatomy, MS and MD anatomy, and this thesis is available on internet. There are 103 or 130 pages, beautifully described all types of calyces. Even all RIRS and PCNL surgeons should go through this. And she has also pointed out almost similar findings about Hodgson and the Brodel type of kidneys. So ultimately, the confusion is increasing more. The Brodel type kidneys, 69% on the right side, Hodgson type kidneys, 79% on the left side, and still they say variation is considerable. This must be appreciated here. After all, regarding calyceal anatomy and the literature about calyceal anatomy, which I have mentioned in the beginning before I tell you which calyx should be punctured, there exists great variation in anterior or posterior orientation of the calyces, and nothing can be assumed and taken for granted. Anatomy is so variable at lower pole also. Only in 58% cases true anterior and posterior orientation of calyces is maintained. In 42% cases at lower pole, calyceal orientation is variable, superimposed, or alternately distributed. So a surgeon who is seeing a patient and trying to plan the puncture, how can he be sure whether he is going to puncture a anterior calyx or posterior calyx? Not only that, patient is practically, he is lying in front of you, either in supine or prone position. You have positioned the C-arm, the fluoroscopic vision. Your needle is advancing forward, and now you want to identify which calyx you are going to puncture, anterior or posterior. Can you identify posterior calyx by certainty in this patient? Let me ask you, this is a patient with the x-rays. Lower pole, there are two stones. Can anybody point out which one is in anterior and which one is in posterior calyx? Not only that, if you want to see the IVU, see the IVU films. Can you tell me which one is anterior and which one is posterior in IVU? This is the IVU film, nicely seen. Anterior, can you tell me which one is anterior and which one is posterior? And on table, when the patient is lying in front of you, he is under image intensifier. RGP is being done. Contrast is going in, and you are seeing such picture which are like IVU. You cannot tell whether and which is anterior and which is posterior, neither in IVU nor in C-arm image intensifier. This particular small stone, IVU shows this stone is situated here. I don't know whether this is in the anterior or posterior. Nobody can tell me. Yeah. I got a CT scan done. Even now in these coronal planes, nobody can tell me whether it is an anterior stone or posterior calyx. Only in transverse section films of CT scan you can confidently tell this stone is in the anterior calyx and not in the posterior calyx. Am I clear on that part?
Yes, sir, very clear.
It is only in CT scan in transfer section you can tell, which cannot be obtained on operation table.
Okay.
On operation table, you have CT images on the view box, not on the screen. Unfortunately, we don't have CT guidance in operation theater. We still have to do all surgeries under image intensifier. So most of the neurosurgeons who recommend entering the pelvic calyceal system through posterior calyx only, they take an oath, they teach only posterior calyx. They recommend use of air as contrast agent for opacification or use of ultrasound. Certainly, ultrasound is the way to go. Ultrasound will tell you which is the posterior calyx, which is the anterior calyx. But again, if you think that air is going to tell you, again, it is a little risky procedure. In 2002, I had one case of hemiparesis. Literature is full of cases of air embolism. And this British Journal of Anesthesia, way back in 2003, the article was published. Urologists are not aware that this is a risky technique, injecting air in the pelvic calyceal system, which is potentially fatal. If any case happens, you will not be spared. This will come against you. So beware. Not only that, we all know patient is lying prone position. This is the width of the kidney, which is usually 3 to 4 centimeter. And the distance between the posterior calyx and anterior calyx is only 1 to 1.5 centimeter. You are injecting air from here. What prevents air from entering here? If just half a cc of air after the whole system gets full, if a half cc air is more injected inside, it will go and fill up here. So it is not that there is a bar that the anterior calyces will not filled up by air. Even if you inject air, air may go into these anterior calyces, and therefore, my opinion and advice regarding posterior versus anterior calyx is don't bother. Don't bother whether it is anterior or posterior calyx. You are there to remove this stone. Practically, there can be only 3 situations. There is a stone in the calyx only, or there is a stone in the pelvis only, or there is a stone in the calyx and there is one stone in the pelvis. These are the only 3 situations. Let us analyze all of them one by one. If there is a stone in a calyx, you have to puncture that calyx only. If you puncture another calyx, if the stone is in anterior calyx and you puncture posterior calyx, there is no point. You will not get this stone. So you have to puncture the stone harboring calyx, whether it is an anterior calyx or posterior calyx. Under image intensifier, you will not come to know which calyx you are puncturing. But as soon as you puncture, if you are in the same calyx where the stone will move. When you pass the guide wire, stone will move. You will be sure. And if it is not moving, you can inject little bit of saline and see if it moves, you are in the right place. So this is how, before you go further, just little bit of saline you inject, and if this stone moves, you are in the right calyx. All those things you can do, and then you go ahead, whether it is anterior or posterior, doesn't matter. Now, if the stone is in the renal pelvis, don't try to choose anterior or posterior. Always puncture the most peripheral calyx. An extensive study by Rinke and they have mentioned that 70%, they have corroborated CT as well as IBU. 70% of the most peripheral calyxes are anterior calyxes. We might be puncturing those calyces only, but under impression that we are puncturing only the posterior calyx. Don't bother. Don't try to restrict. Puncture the most peripheral calyx with the thinnest parenchyma over there so that there is no bleeding. There should be a wide infundibulum like in this case. this particular calyx. Now you must be aware, this particular kidney, in the lower pole, there are two calyces, and the medial one will be anterior, and the posterior, the lateral one will be posterior calyx. And fortunately, that is the most wide calyx, so that my in and out movements will be free and in the same alignment where the stone is. So you should puncture the most peripheral calyx with thin parenchyma, wide infundibulum in alignment with this, so there is no angulation, and remove this stone. So in this, if this is a Broddel's kidney and you are trying to remove this stone, you will be coming through the posterior calyx. But you will not know whether it is a Broddel kidney or a Hodgson kidney. And if it is a Hodgson type of kidney, the most peripheral calyx will be the anterior calyx, and you will be puncturing anterior calyx and walk through into the pelvis and remove this. So you should talk about the most peripheral calyx. Third situation, if there is a stone in the renal pelvis as well as in the calyx. Again, because on the way, you have to take out the stone. So always puncture the stone bearing calyx so that you can remove the stone in the calyx as well as in the pelvis through the same track. So always take this track. You will be able to remove the stone, move the stone, whether it is in anterior or posterior. When the stone starts moving, you are in the stone harboring calyx, then proceed further and move the stone. So in all the three situations, practically, there is no need to concentrate whether it is a posterior calyx or anterior calyx. Puncture the calyx and come out. Don't bother anterior or posterior. If you choose, this is a situation, if you only want to go through the posterior calyx and your stone is lying in the anterior calyx, if by all means, by ultrasound and all, you come only through this, removing this stone will be almost impossible through this track. So you should always in situations choose when there is a calycial stone, you should choose the stone bearing calyx and the most peripheral calyx. Remember, in about 11.4% of the cases, there is a perpendicular minor calyx. I always call it as a parapelvic calyx. 11-12% is a big percentage. Such stones are mentioned in ultrasound as stones situated in the renal pelvis, but they are not in the pelvis. They are in this parapelvic calyx. These stones cannot be removed because infundibulum in such cases is very small, and these stones can only be removed through the direct puncture. No posterior or anterior, direct puncture into this particular stone bearing calyx and remove the stone. This is how the parapelvic calyx looks like in IVU. If there is a stone in this, you will have to directly puncture it. There is no anterior posterior which will lead to this particular. Thank you very much for giving me this opportunity, Dr. Chandra.
Oh.
I hope I have put my point across that
Yes.
don't bother about posterior anterior. Be a surgeon, bold surgeon, remove the stone for which you are proceeding ahead. Thank you very much.
Thank you, sir. With your permission, I will close the screen and then, yes, sir, you already done it. Certain doubts I have, that's very crisp presentation, more or less revision. Maximum beneficiary in this program pure is me only, because I will be going, the surgeons are going into minor details, especially I'm really emotional to say that 130 pages. Have you read that, this thing, sir? Tamil Nadu.
Yes.
Great.
It is very interesting.
My
very interesting. You must go through it. It is available on internet.
Great. That is a very, very interesting, sir. Sir, generally, the problem arises when the infundibulum is very long. If the stone is harboring in the calyx and infundibulum is wrong, then you have to be stone guided, as you said, if the stone is in the calyx. If it is radiolucent, then we were taught when we were MCH students that when you are injecting the contrast, you should see which calyx gets filled first, which gets darker, which calyx becomes later filled and lighter. They are the anterior calyces. Does it apply true, especially if the stone is not very visible in CM? If the stone is visible and large, half of our stress is done, because somehow we can hit and you can feel, or somehow on that day we can somehow something we can do. But if the stone is not visible, faintly visible, the moment you inject contrast, especially juniors inject thick contrast, even if the senior enters into the room, he doesn't know where it is. At least if you see in the beginning, okay, by chance senior comes after the thick contrast injected, nothing, beautiful RGP, but stone not very well seen. So in that situation, how do you, some clue has to be there for anterior, posterior. Does 30, my straight question is, does 30 degree, 0 degree can help sometimes in puncturing that specific calyx?
Certainly. Now you have raised 2-3 points in this discussion. One thing, the density of the contrast. Always the density of contrast should be less diluted. Sorry, it should be less opaque as compared to the stone. So what I do is, only when the patient is lying prone and the stone is visible, because depending upon the thickness of the patient as well as your CM unit, the radio opacity may differ.
Yes,
so
sir.
You have to fill up the syringe with the contrast, and contrast filled syringe you have to bring on the back of the patient and compare the radio density of the stone and radio density of the contrast which you are going to inject. If your contrast is darker, you have to again further dilute it, because we have to just faintly outline the pelvic calyceal system. That is enough for us. So don't inject a high density contrast. Stone should be seen as a filling defect. Always when the dye is going in, your needle tip should be placed onto the stone to identify that this is the stone. Then you start injecting the contrast. Don't inject contrast before. And when the dye goes in and starts filling all around all the calyces, you will realize where your stone is. So although stone might get obscured by the contrast, then you at least have a good knowledge where this is. So don't do RGP or injection of contrast before positioning the patient, before touching the with the needle, indicating the stone with the needle, and with the dilution, more diluted contrast.
Yes.
These are the tricks. Regarding whether the posterior calyx will fill up, this, when we dilute the calyx, this contrast to that level, those days are gone. When we really, without dilution, we used to inject the contrast.
Yeah.
Now we have advanced much further. So that time the contrast density used to be really heavy, and contrast will settle down. Now, as soon as you inject, you must have seen, you are doing so many RIRS, so many PCNL. When you start injecting the contrast, it goes like and starts filling, gets diluted in the already existing urine or in the fluid. It does not remain a separate contrast entity which will settle in the posterior.
Okay.
The whole pelvic calyceal system, which is more easily approachable. If the stone is obstructing the infundibulum, or stone is obstructing the PUJ, or any part of the kidney, contrast will not go beyond.
Yes.
But wherever it is freely going, whether it is anterior calyx or posterior calyx, it will go, and density of the contrast is much diluted to say that they will always settle and outline the posterior calyx first and the anterior calyx later. Okay. Sorry, anterior calyx first. That concept should not be there.
That should not be used. Okay, yes. Sir. My second question, in superior calyx, usually lateral part of the calyx is punctured if it is not a cup which is facing laterally. If the cup of the calyces are facing superiorly and adequate amount of the lateral wall is seen still because of the large calyx, can we puncture non-calyceal lateral part of the calyx and still get away without bleeding. Because if you really want to puncture superiorly, it may go above the 12th rib, then your entry point will be minimum above the 11th rib, which we are not comfortable. In that case, can we puncture laterally? As you mentioned, that anterior posterior is not there. It is a globe type of this thing. So bleeders won't come on the lateral aspect. So what is your comment?
The major bleeder in the superior pole is posterior segmental artery, which is crossing the infundibulum of the superior calyx. Mostly 67%, 57% of the times, the junction between the superior calyx and the renal pelvis.
Superior
If you puncture superiorly, anywhere at the upper pole, anywhere, so whether you are coming laterally or little medially, the amount of bleeding will remain same. So it doesn't matter. You don't have to be very, very specifically to the cup of the calyx only in the superior pole. From wherever there is a good dilated area and a parking space you can find, you can puncture.
Right, sir.
Therefore, the supine PCNL, there is a restricted entry.
Yeah.
In superior pole, very small portion is approachable in supine position.
Yes, sir.
The superior pole. So you can gain entry from there. Only don't come closer to the infundibulum. Remain high. Pleural injuries can still be managed.
Yes, sir.
If you injure the posterior segmental artery, there will be huge amount of bleeding, ultimately infarction and AV malformations and serious consequences.
Yes, sir. So my third question, we say that when you pass a guide wire, after a good urine coming out of the needle, if the guide wire is not freely going into the pelvis like a curve beautifully, people say you have punctured anterior calyx, take it out. Generally, they talk like that. No, yeah, it's going down and then coming up and then going into pelvis. That beautiful curvature like this smooth, we feel that curvature is not there. Somewhere some S is there and you will get clear urine, but if you start dilating it, somewhere after 10 dilatation, you will see the bleeding. And you will not be able to go to the tip of that infundibulum or the pelvis in such cases. What is this point exactly? Is it that your tract is not correct, or is it that the anterior calyx should not be chosen in that angle?
We label it as anterior or posterior calyx for our understanding. As such, there is so much of variation and so much of angulation in the same area of the true pelvis. One is going like this, one is going like this, means there are different angles.
Yeah.
Whether anterior, posterior, medial, lateral, if any calyx which is not in nice alignment, in three-dimensional way with the renal pelvis, then there will be some amount of tissue at the level of infundibulum.
Okay.
If it is angulated like this, and if you are going through this and it is angulated.
Okay.
If this is angulated, your guide wire will go in, may go in. You will not realize at that time. But when you are dilating, dilatation is being done by the straight instruments.
Yeah.
So it is not straight, it is little angulated. So it will cause fulcrum effect and will cause injury and bleeding will take place. So don't label it anterior or posterior. It is not aligned.
Aligned. Okay.
It is not aligned. Any good aligned calyx will give you a nice entry and a good dilatation.
Okay. Sir, generally in a lower pole, if you have not done dilatation properly, usually when compared to middle calyx, lower calyx punctures bleed a lot. Is it correct, sir? Lower calyx dilatation, bleeding will be more.
Not necessarily, but if there is a good article where by Sampaio only, where he has shown 34% of cases there is a collar of venous sinuses in the lower pole.
Okay.
If by mistake you enter that particular venous sinuses group, then the bleeding, it is always venous.
Okay.
Whatever you are mentioning in the lower pole is always, not I will say always, but mostly
Most
it is
of the times.
it is venous only. It is troubling you during surgery, but post-operatively it settles down and there are no AV malformations or angioembolization is not required.
Required. Okay.
I'm sure you must be having this similar experience.
Yes, yes, sir. It
So,
stops, sir. But only
during
problem is,
surgery,
till you see the stone, the bleeding will be torrential. Sometimes it causes annoying bleeding in the, if you are, especially narrow infundibulum is there. If by chance, if you have gone closer to the infundibulum, your dilatation, they till the ampla sheath settles, it completely obscures the vision. We will be afraid.
But post-operatively, they don't trouble you.
They don't bleed that much.
Don't trouble you much. Within a day or two, your everything becomes clear and they can be discharged. There is
Sir,
not
as you said, my fifth question, if two calyces are angulated and if you have little confusion in which calyx the stone is, and you attempt and you carefully puncture thinking that it is stone, and by chance if you don't see the stone in the pelvis, in the calyx, and in X-ray by the time nicely stone so far not seen, now it will be seen nicely just behind your ampla sheath. Can we come back and do Y puncture within the parenchyma or not? We get tempted that again doing everything by 0.30, guide wire also doesn't go. So a little bit back we come, especially in a stone which is reasonable size, not less than 1 centimeter. If it is 1 centimeter, again by hitting carefully the stone without, I mean, by track. Basically, I am asking, if the stone is not seen in your calyx, it may be some angle between you misjudged, and what will you do? And while doing that puncture, bleeding happens, sir. If the ampla sheath is not taken out and kept there only, bleeding through the ampla sheath suddenly increases. Even you are in periphery. But if you remove the ampla sheath, you can nicely, comfortably start fresh one, which is more correct.
Hats off to you, your experience and your description. It really, your question shows the tremendous amount of experience you have. This is what happens when there is a anterior calycial or a stone in one calyx and you have punctured another calyx.
Yes, sir.
If the stone is in the anterior and you have punctured by mistake the posterior. Now going from posterior to anterior, on the way you will be encountering those large intersegmental vessels between the two calyces and the bleeding will be torrential. So even if you have to do Y puncture, that is better, you come out through the posterior calyx and then angulate more and puncture the anterior calyx. But what is my plea or my system is, when I can identify this stone in image intensifier,
sir,
it is not being seen through my nephroscope, but it is being seen under image intensifier somewhere closer to my amplat sheath. Then I will take a needle and directly puncture the stone, lateral border of the stone, and give a good flush.
Okay.
Stone will come in front of me.
Okay. So that is
80%.
That happens, very happy.
I can assure you, no need of making a second track. Just flush a anterior calycial stone will come through the infundibulum and will come in front of your amplat sheath, because when you are giving flush, the water has to come out of the least resistance area. And the least resistance at that time, that area is the amplat sheath.
Yeah.
So if you are injecting, the fluid is coming out of the amplat sheath.
So that's
that whenever 3-4 syringes, if you fill 20 ml syringes, the stone will come in front. If it doesn't come, then anyway the Y puncture is the only way to go.
Sir,
don't go through and through. It will be bloody.
Yes, sir. Sir, after doing a perfect puncture, when you go with nephroscope inside, after the dilatation, suddenly if you have gone beyond or posterior to the puncture, you will see always fat-like thing, which we think that outside the kidney it is. But it is submucosal fat-like thing will be there. It is not parenchyma, but the glistening surface appears that you have perforated badly, But when you do contrast, it is not that bad. It just haziness will be there. What is this reflecting flat-like thing just because below the mucosa? And once you finish the procedure, okay, you will be comfortable. Small stones will settle there. You don't want to do anything. You think that you are in the outside the kidney, but it is not. Why that glistening surface is seen?
See, if you study the anatomy, there is all around the kidney, there is fat. All around the pelvic calyceal system, there is a fat padding. In the pelvis, if you must, I don't know whether in your era you were doing pylolithotomies open, you have vast experience of that or not.
Not vast experience.
We were fortunate when PCNL was not there and we were doing all pylolithotomies. So we were doing Gilbert net dissection and then in between the renal sinus dissection. There is all fat all around. There is a good padding of fat all around. Even when you are operating, and if it is a case where there was a lot of pain and the patient came at that time, there will be edema of the pelvic calyceal system, this mucosa. Any tear in the mucosa, immediately outside there is fat.
Oh,
Any tear in the pelvic calyceal system anywhere.
okay.
It will not be very obvious. It is not a big tear or a big hole through which nephroscope will go in. But
Okay.
any tear in that, a minor tear also, and if it opens up, you will be seeing the fat. So, and when you inject the contrast, it may not extravasate.
Extravasate.
You will feel that when inside there is no fat in the kidney.
Okay.
Inside the pelvic calyceal system, as long as you are safely inside the pelvic calyceal system, there is no glistening fat. So any appearance of fat means you have just outside the kidney.
Okay, sir. Sir, if in case if you are doing lower calyceal perfect puncture to the stone, while doing the puncture, if the stone slips into pelvis and goes into middle calyx, once you have seen that the stone is not seen and X-ray it is seen nicely in middle calyx. Again, don't tell that I will flush with saline. Say, tell something else I am asking. When I try to go into that middle calyx with torque, first thing as a common sense, I take a smaller scope. I withdraw the ampulla sheath out of the kidney, sometimes with a guide wire. To what level junior? People say that it will tear and lead to torrential bleeding in the middle calyx if you do wrong trying to chase the stone from the lower calyx. Usually experienced persons will have that feel that how much you are bending. What are the tips and tricks to go from one calyx to other calyx to remove the stone, and when you should stop it?
It depends upon the compactness of the pelvic calyceal system. If there is a stone at the PUJ for quite a long time and the whole system has become petulous,
Okay.
preoperatively you see a hugely dilated system, then traveling from one calyx to the other calyx is not going to give any trauma.
Yes, sir.
Or torque. So it depends upon, during surgery, the system gets collapsed.
Yes.
We have to give so much of fluid inside, but still it is malleable if it was previously dilated. So go and see the previous CT urography or IVO films and assess how much the system was dilated. If it was dilated, you can take a chance and go from lower calyx to the middle calyx or all other calyxes you can travel. But if the system has always been a compact system, don't try to go from one calyx to the other, particularly from superior or inferior pole. Don't go to the middle calyx that is almost at 80 to 90 degree of this axis of our straight instrument. So turning 80 to 90 degree and going in will give a torque. And if it is acceptable to the kidney, it won't bleed. But if there is a compact system, you will immediately start tearing the portion. There will be fulcrum effect. You will start tearing that portion where you are trying to bend, and then it will bleed. So, or same way, if you start seeing the fat, if you go from there gently, come back and see whether whatever track you are traveling, whether it is enough, it is okay for the kidney or not. If there is a little tear and if you start seeing the fat, then stop. Don't do that.
Yes.
Don't go from then. Use a flexible instrument
Yes.
or push, saline push.
And then that is a good option.
Yeah.
So last two, three questions. One question from the audience is that if the ureteric catheter slips out during turning the patient back, it happens quite often, in fact, 5% of the cases. And some people say if you have injected already, some amount of contrast will be seen so that you can puncture that and do if you don't have ultrasound. But if you don't, you said that you don't inject anything, happily ship, nicely sister pulled out the ureteric catheter to lower end. And whatever contrast you are injecting, it is not filling the calyx. Then how will you do it, sir? If
Bring the patient back in the same position and put the ureteric catheter.
you'll change the position?
Particularly unless you have done at least 200, 300 cases.
After 200, sir?
After 200, 300, you are confident little bit and maybe stone guided punctures, and that way you will be able to manage. Otherwise, we don't know. A ureteric catheter is beneficial in 10 ways, which I always point out in Percon. Without your knowledge, ureteric catheter putting inside is a great, I will say that it is a great help. It gives a strength to your procedure and it gives you a stability and confidence for you.
Yeah.
So in the beginning itself, it has come out. There is no time, and even 10 minutes, 15 minutes, you have to put back the patient in lithotomy, again do a cystoscopy and put the ureteric catheter in.
Yes.
When you inject the contrast and even a drop of contrast is not going in the PCS, it is only coming in the ureter and coming back. No, don't accept it. Again, put the patient in lithotomy, put your ureteric catheter right up to the upper calyx, and then do it again.
Yes.
No problem.
Last two questions, sir. One person, Mushtaq Ahmad, has asked, please give tips for the horseshoe kidney puncture. It's a very big topic, but in a nutshell.
Horseshoe kidney, it is the superior calyx which is most easily accessible and the most ascent, higher up, from where you can gain entry. And when you enter into the posterior, into the superior calyx, the most of the pelvic calyceal system, except the isthmic in these calyces, they can be very well visited through the superior calyx. So don't try to take out from any other way. Only superior calyx should be your preferred choice.
Okay.
Secondly, horseshoe kidneys or any anomalous kidney is little deeply situated inside. So in normal circumstances, if you puncture and if you start getting the pelvic calyceal feel or entry into the PCS in about 3 centimeter or 4 centimeter, in horseshoe, you will have to go 5 centimeter or 7 centimeter deep inside.
Yes.
So your needle should be long. Your instrument should be long. Your implant sheath should be long, particularly if you have to remove stone from the inferior calyceal. So you are entering from the superior calyx. Good length is wasted from the skin up to the superior calyx, and another good length gets wasted in the pelvic calyceal system till you reach to the lower stone.
Yes.
So good lengthy instrument should be there with you.
Sir, my last question. In the era of CT, the IVP is literally gone away. Training, teaching, teachers, everybody is not doing it. What we will miss predominantly by not doing IVP?
By not doing IVU?
Yeah. Are you doing it? Do you recommend it? If so, because bifid systems are missed and some disasters happen with cross calyceal puncture if CT is not read is the only thing I know. But generally we are not doing IVP. What is your opinion, sir? Because you have seen the era of too much IVP and you are seeing the era of CT now in the peak phase of your career. So when you feel that, okay, CT is enough, fair enough? Or CT IVU? Some says that CT IVU is must for stone.
See, we cannot say a must because financial reasons, there are so many, and particularly when the renal parameters high, you cannot do any IVU or any CT IVU. So you have to depend only on plain X-ray and non-contrast CT when the renal parameters are high. So it is doable even if renal parameters are normal. Again, then you can do. But then you should be prepared for the surprises on table. Because if the CT IVU or a real means normal IVU IVP is there with you, you are much more comfortable, and in pre-operative phase only you have decided whether I will be going through this calyx. At least to choose two calyxes. Not always in the beginning you will be able to puncture the calyx which you want. You will try many times and that calyx will not be able to, you will not be able to puncture, and you should always have in mind a second alternate choice of the calyx which is going to take you to this stone. So in a good IVU, you can pre-operatively plan. There won't be any surprises and stress level will be low. You know that if this calyx is not working or there is extravasation in this, I will choose the other one. Mentally, you will be prepared.
Yes.
Secondly, the three-dimensional anatomy and relationship with the ribs and other bony structures is very nicely appreciated in IVU rather than in CT. In CT, you see different pictures, different phases, and then in your mind, you have to conceptualize particularly how the pelvic calyceal system will be in relation with the bony cage, the superior calyx, the relationship between 11th, 12th rib, and the superior pole. So IVU gives you a real feeling, real image, what you are going to see on table. CT, you have to have a third dimension in your mind. That is only the picture in your mind, unless you get the 3D reconstructed images with the bony cage, with the stones, then it is as good as IVU. Another big advantage of IVU is done over 1.5 hours. At least 5 situations you have to take, 4 or 5 pictures you take. And patient doesn't lie down continuously on the table.
Yeah.
1.5 hours. He will go out, then he will come back for the second picture like that. So therefore, I will recommend IVU when there is a colonic problem also.
Okay.
Because the movement of the colon is well appreciated on the 5 films.
Okay.
Yeah, in CT, only that particular 3 seconds or 5 second exposure. That's all. Rest all is constructed on that.
Yes, sir.
So regarding neighboring organ, regarding colon, particularly, just a minute.
Sir, last thing, Parkan is there in the month of October. Would you like to say briefly about that? No conflicts of interest. We all see a lot of people have access to a different angle. I'm surprised. Facebook, some urologists never see Facebook. Some never see WhatsApp. Some never see mail. So modes of telling the information is also, because this is usually 1,000. You know one thing, sir, SK PAL, sir. You know one thing. In fact, the highest number of viewers in a surgery in my 956 videos of pure as well as Preeti Urology and Kidney Hospital is your PCNL live workshop is seen 45,000. This is the highest, 45K in my YouTube link. 45K. Is say highest, there is only one thing, that is a different issue. Dance ka hai, that is 20 lakhs. But in a urological surgery, highest viewed is this. So you never know how this reaches to the public. By tomorrow, 1,000 people. Today, actually, 180 people have seen the program. Most of them will be juniors, and they wanted to come for these conferences. We always think about seniors who are already doing it. Nearly 1,000 in 3 years. 1 year, you will get around 300 people who are in the final year passed out. They may come. So briefly, you want to announce by slide, or you wanted to tell?
Yeah, I would like to say, because nowadays there is an era of excellence.
Sir.
And you cannot be excellent in every field.
Yes.
So you have to concentrate only on one thing.
Yes, sir.
Since last 37 years, I must read at least 1 to 2 hours every day on some aspect of PCNL.
Great.
Like the thesis which I mentioned, it was so interesting, 130 pages. And I really feel pity. People do 50 cases and get published and get professorship.
Yes, yes.
Because they are not from our part of the world.
Yes,
Our
sir.
Indian, this girl, I don't know her, but she has done 100 cases of cadaveric kidneys. She has done study of 100 cases. And she has no mention anywhere.
My God.
So this is what, and if you see that particular thesis, your eyes open up how the stone calyces and how from where the stones will go, all those parameters of the width and length of the infundibuli, the angulations, everything she has mentioned. So if you read only on one particular thing, right from 10 years, 15 years, 20 years, only on that particular thing, then you can go into depth of that.
Yeah, no doubt.
And then your confidence will be there. You will be able to, even if there is somebody who is trying to challenge you, you will be more confident because you are well read on that particular.
Yes, yes. Sir.
So I will give this message to youngsters. They will definitely get 1, 2, or 3 points out of per con.
Yeah.
Life is a learning process. There will be some points will get discussed accidentally. Even for 1.5 day per con, not everything about PCNL can be discussed. There is so much of literature on PCNL, so much of literature. So something everybody will come to know. I learn from every per con 2, 3 points. I catch, I note down. This thing in last 37 years, I never knew. This thing now Chandra Mohan has taught me. This happens. So like that, we should attend. If you want to excel in one particular thing, concentrate on that. And
this conference will be only on PCNL, sir. All surgeries will be PCNL only.
No, in practical world, I do all other surgeries
No,
also.
sir. In your PERCON conference,
only
PCNL.
Only
PCNL.
Only PCNL.
Okay. In and out. Only 1.5 day is PCNL.
Only PCNL. Right from beginning, all PERCONs are that, and it is on 30th of September and 1st of October. This year? This year.
30.
I always come around 2nd of October. Gandhi Jayanti.
Okay. So that holiday will be there.
Remember that Gandhi Jayanti we have to celebrate.
Yeah.
Then last year it was on 1st and 2nd of October. This year it is one day before, 30th September and 1st of October. So 2nd October is Monday. You will have enough time to travel and go back. So must come.
This conference is in which hotel, sir?
Same, Surya Hotel.
Surya Hotel. So people can book the room in Surya Hotel and stay and watch everything.
Yes.
That is the advantage.
Yeah.
That is the advantage. Fine, sir. Thank you very much.
Thank you.
Every time we learn something from you, and the amount of dedication you have. I have seen once when I am telling the ampla sheath, 15 French is there. Chandramohan, there is no 15 French ampla sheath in India. Where did you get that? Then I cross-checked. It was 13.8. That is also Shali. So there is no 15 French nephroscope, you told in the group discussion. So that is the amount of the knowledge you have, sir. Great. Highly appreciate it, sir.
Thank you. Thanks for giving me this opportunity.
Thank you very much, sir.
And once again, wish you all